Long case history of a case of heart failure in the background of ischemic heart disease. Mrs. ABC, 64 years old, diabetic lady, resident of Peshawar. A known case of ischemic heart disease presented to emergency room 5 days back with complaints of increasing shortness of breath for the last 3 days. Patient was dyspneic at rest and had orthopnea and PND. These symptoms were associated with sweating and sinking of heart. However, there was no history of chest pain, dizziness, nausea, vomiting, or loss of consciousness. There is no history of any prolonged bedridden state or long haul travel leading to leg swelling, no history of productive cough, hemoptysis, or fever. She denies any history of shortness of breath in any specific season. She was admitted in emergency department where an ECG, X-ray, and some other labs were sent and managed with oxygen inhalation, oral and injectable medications, Foley's catheterization, and stabilized. Shifted to step down unit the next day. Echocardiogram was performed that showed EF 30%. Patient has long standing history of her symptoms. She had a myocardial infarction 4 years back and has been on treatment since then and used tablet aspirin 75 milligram once a day, tablet rosuvastatin 20 milligram in the evening, tablet metoprolol 25 milligram twice a day, tablet lisinopril 5 milligram in the evening, tablet spironolactone furosemide 40 or 50 once a day and had been in NYHA class 2 and Canadian cardiovascular functional class 1 before the current ailment. Patient had skipped her drugs for last 1 month. She underwent coronary angiography 2 years back, which revealed disease in her three vessels and was advised cabbage, but the patient refused that. Patient is diabetic for the last 15 years on insulin 70/30 is 25 units in the morning and 20 units in the evening. He has variable compliance and poor glycemic control. Her last HbA1c was 8.7. She complains paresthesia to her feet and according to her she has creatinine 1.9 mg per deciliter. There is no history of visual disturbance. She is non-hypertensive. Lipid profile is unknown and she is non-smoker. Her father had premature coronary artery disease. On systemic review, she gives history of hemorrhoidal bleed off and on and has been advised surgery. At present, there is no active bleeding. She gives history of calf pain when she starts walking and settles when she takes rest. There is no history of stroke, fits, vertigo, neck swelling, weight loss, night sweats, altered bowel or bladder habits, hematemesis, melena, hematuria, joint pains or swelling. Rest of the past medical, surgical, gynecological, and drug history is unremarkable. She is not allergic to any drug or any other substance. Is married, having 4 children. She gives history of oral tobacco chewing. He has sedentary lifestyle and unhealthy dietary habits. Her mood had been stable but gives history of loss of appetite for the last 1 year. She lives in a small house and her husband is a businessman belonging to lower middle class. On examination, an elderly lady lying in the bed with an IV cannula on her right hand remained cooperative throughout the examination, is hemodynamically stable with a pulse rate of 88 beats per minute, regular, normal volume, normal character, no radial or radiofemoral delay. All the pulses are palpable and comparable. Her blood pressure is 160 with no evidence of postural drop. Respiratory rate 20 per minute. Temperature 98. The patient looks pale and has corneal arcus and there are no tendon xanthomas, xanthelasmas or transverse ear crease. JVP is not raised, but the patient has pedal edema. There is no clubbing, cyanosis, or jaundice. On precordial examination, there are no scar marks, visible pulsations, veins, or striae. Apex beat is at 8 centimeter from the left sternal border in fifth intercostal space, which is normal in character. There is no left parasternal heave or any thrill palpable. On auscultation, the intensity of first and second heart sound is normal at their respective areas, and there is no murmur audible. Chest is moving symmetrically with equal air entry bilaterally. Normal vesicular breathing. There are bilateral basal fine crepitations. Abdomen is soft, non-tender with no evidence of visceromegaly. There is no carotid, subclavian, renal or femoral bruit. Her cranial nerves, sensory system, and motor system are intact. On limited fundoscopic examination, I could not appreciate any finding. Her waist circumference is 36 inches. So, based on this history and examination, my diagnosis is heart failure in the background of ischemic heart disease, most likely of atherosclerotic in etiology. A short summary will be: a 64-year-old diabetic lady, a known case of ischemic heart disease and LV dysfunction, non compliant to the treatment, presented with shortness of breath, NYHF 4 symptoms, managed medically, and at present the patient is stable.